Hello everyone, I am Dr. Sandeep Sharma. I welcome you to this pediatric recall pattern discussion of NEET SS 2022, the pediatric part. See, exam has just been held, and so the topics we'll be discussing, they will be very similar to what were asked in the exam, and they are based upon the recall. However, there are a few disclaimers I need to tell before I start the session. So this is a recall based discussion and questions are only indicative. So rather than running after the question, you should focus more on the topics and how the questions are being framed. I will be talking about the possible ways questions could have been asked in the exam, and I will be talking about whether it was a difficult question, it was a repeat question, or it was an indirect repeat, so that you get an idea how the paper pattern is evolving compared to the previous years. And the answers of MCQ obviously will be liable to change if there is a statement change. Suppose the question simply inserts a word not or all except, the entire question changes. And of course, you already know by this time that the answer of a question depends upon the options given to you. So if there is a better option given or there is a missing option, the entire answer of that question will change. So let us begin with the discussion. Firstly, I will talk about the analysis of the exam. See, about 10 to 15 MCQs were very tricky and tough. I have taken a lot of interviews of the toppers very recently in the last couple of days, and I found that most of them said that they attempted somewhere between 135 to 142. There were people who attempted close to 150 also. There were people who said we attempted about 130 also. But majority of the top rankers, they attempted between 135 to 145. And they said about 5 to 7 questions, depending upon how good their attempt was, they were kind of unsolvable. If you look at the entire paper, about 10 to 15 MCQs were very tricky and tough. Then about 10 to 15 MCQs were modified repeat from the past papers. Questions like those related to Dye-George syndrome, questions related to Bombay blood group, they were all repeats. Then there were 20 odd MCQs which were very easy or straightforward, like they were asking about a simple question as tocilizumab being an interleukin-6 antagonist. So it was a simple one-liner kind of question. And then remaining 100 MCQs were good standard MCQs, and they were taken from every part of the pediatrics as a subject. And there was slightly more weightage for systemic pediatrics compared to general pediatrics. Having said that, there were questions from general pediatrics, there were questions from genetics, there were questions from malnutrition, there were questions also from the indirect questions from the usual things that we read in our residency days. So let us start with question number 1. The question number 1 I have deliberately taken because a lot of you have got it wrong in the paper, including some of the rankers which I took interview of. So question number 1, first have a look. A child with PSGN, post-streptococcal glomerulonephritis, has nephrotic range proteinuria. This is the key word that you need to understand. Nephrotic range proteinuria does not happen normally in streptococcal nephritis. What you find is subnephrotic proteinuria. So the renal biopsy is indicated if persistence of this proteinuria occurs beyond what time? And 4 options were given: 2 weeks, 6 weeks, 8 weeks, 12 weeks. After the exam was over, there were a lot of students who were discussing among themselves on social media. They were also asking, they asked me also, sir, 8 week better answer hai or 12 week better answer hai? The answer is none of C or D option. The question is not asking about when proteinuria will persist that you will do renal biopsy. You know that post-streptococcal nephritis, renal biopsy is normally not needed. But there are certain scenarios where you need to do renal biopsy. For example, if the patient is having persistently low serum C3 level, usually beyond 8 to 12 weeks, you need to do that. If the person is having persistent proteinuria or hematuria beyond 8 to 12 weeks, then also you will do. This question is asking about nephrotic range proteinuria. Let us have a look at what the textbooks say. Nelson, 21st edition, says that you should be doing renal biopsy is considered. Look at these lines. It is considered when hematuria and proteinuria or diminished renal function or a low C3 level persist more than 2 months after onset, right? They simply say hematuria or proteinuria more than 2 months, that is more than 8 weeks after onset. That is what I have said also. I have discussed in my videos also, 8 to 12 weeks is the time. If it persists beyond that, you would go in for renal biopsy. However, about nephrotic syndrome, it says renal biopsy should be considered in the presence of acute renal failure, nephrotic syndrome, normal complement, or absence or evidence of streptococcal infection. It does not talk about the period associated with nephrotic range proteinuria. The question is asking about nephrotic range proteinuria, so Nelson does not really help in solving this question. Look at the Indian textbooks, including those by Dr. Arvind Bagga. It says you should do renal biopsy where there is delayed resolution, and look at this point. Nephrotic range proteinuria, if it persists beyond 2 weeks, then you will go in for renal biopsy. And that is why the answer to this question is 2 weeks. I know it is very controversial, but if you go and try to read all the Indian textbooks, including IAP, including the pediatric nephrology textbook, you read the review articles, you will find that yes, nephrotic range proteinuria should not be there. And Nelson is very strict. You should do biopsy if there is nephrotic range proteinuria, but you can't solve the question with that. All the 4 options. You have to choose a time period. And Indian textbooks and most review articles, if you go into detail, they say if nephrotic range proteinuria is present, you should plan a renal biopsy. But it must be done if it is beyond 2 weeks. Nephrotic range proteinuria beyond 2 weeks, you have to do biopsy. And that is what this question was also asking. A very controversial question. Most of the rankers, including a couple of students in the top 20 ranks, also got it wrong when I discussed informally with them. So what it shows is it was a very, very standard paper. It was not a paper where you would, simply sleepwalk into and get a rank. It required highly accurate approach. So question number 1, answer is 2 weeks. Let us move further. Question number 2. An infant with irritability, regression of milestones also has opisthotonous posturing, intermittent hyperpyrexia and optic atrophy. Which of the following enzyme deficiency can be associated with this condition? Now remember, whenever there is a regression of milestones and the patient is not having any hepatomegaly, he is having hyperpyrexia, opisthotonous posturing, seizures and visual problems like optic atrophy, you should always think of a disease called as Scabies disease. So which of the following enzyme deficiency can be associated? Look at these 4 options. Among them, we know that Scabies disease is due to deficiency of Galactoserebroside, beta-galactosidase, and so the answer to question number 2 is B. Let us revise a few points related to Scabies disease. Nelson 21st edition says it is a autosomal recessive neurodegenerative disorder where there is severe myelin loss. It says that myelin destruction is the problem rather than myelin not getting formed. And there is presence of globoid bodies also, or called globoid cells in the white matter. Now this enzyme which is produced by a gene called as GALC, it is present on chromosome 14q, and the deficient enzyme name I've already told you. This beta-galactosidase enzyme is involved in the metabolism of galactoserebroside. If this enzyme will be deficient, there will be accumulation of this galactoserebroside. So galactoserebroside, beta-galactosidase is the enzyme, right? ये enzyme नहीं होगा तो its substrate known as galactoserebroside will accumulate. It will form globoid bodies and they will cause destruction of the white matter, destruction of the myelin sheath, and so oligodendroglial damage will happen in these patients. So these patients have onset in infancy. There is irritability, hyperpyrexia, vomiting, feeding difficulty. Sometimes due to vomiting and feeding difficulties, they are also mistaken or they tend to mimic milk allergy or cow's milk protein intolerance. They can sometimes mimic. So they can ask you as a further MCQ, as a one-liner in future exam, or in Vivas it can be asked that which condition has developmental regression and mimics milk allergy. If this much of information is given to you, your first possibility again should be Scabies disease. Please note it down if you are listening to this and adding to your notes. And later on, you will find these patients have seizures, regression of milestone, opisthotonous posturing, optic atrophy, and most patients die by 2 years of age. So they die by 2 years of age. So answer to question. Next we come to question number 3. There was a question, as I said, on interleukin-6 receptor antagonist. The answer to this question is obviously tocilizumab. So tocilizumab is interleukin-6 receptor antagonist. It is not an interleukin-6 inhibitor. No, it is a receptor antagonist for interleukin-6. And tocilizumab is often indicated in severe infections, severe inflammations wherever there is cytokine storm. Most patients with cytokine storm due to COVID-19 infection, due to multi-organ dysfunction syndrome, if they involve interleukin-6, tocilizumab is often found to be effective. Question number 4. All are true regarding scabies in a child except scabies. Now scabies is one topic which we normally do not read much when we are in our residency, when we are doing MD, TCH or DNB. We don't read it much. But when you go into field and you go into practice, trust me, in particularly the humid environment, humid areas of the country or in the rural areas, you will have at least 2 to 3 patients of scabies coming to OPD on a monthly basis. So it's a very, very common skin condition. And scabies can be clinically diagnosed, can be managed by a pediatrician. You can take a skin opinion, you should take a skin opinion if there is doubt, but it is manageable by a pediatrician as well. And this question is checking your knowledge of scabies because pediatric dermatology they are asking. So scabies in a child except, let us look at the options. A. Causative agent is Sarcoptes scabii belonging to arthropod. So the causative agent, yes, it is correct. They are asking all are true except. So this is a true statement. Causative agent is female Sarcoptes scabii pathogen which is responsible for scabies. Second is rarely spread by fomites. It is a true statement. Nelson clearly says that the mite is short-lived. So prolonged direct contact with the person and sometimes with the beddings, infected beddings, the scabies can be transmitted. So when you are staying or you're planning to stay in a low quality, hot, humid hotel which has low hygiene levels and there are people, coming there, staying and the bed sheets are not getting changed, those are the places where scabies gets transmitted. All the infected bed sheets, or close contact with people who are infected, this bug can be transmitted. However, fomites is a rare form of transmission. It can be transmitted, but it is a rare form because the mite is short-lived. It is a direct line mentioned in Nelson. Third is nodular scabies is seen in AIDS patient. It is a true statement. Now, the classic scabies that we see is the so-called Scabies Vulgaris or the common classic scabies. That typically causes problems in infants and children, and the interdigital spaces, and in infant it can happen on the face also. The usual burrow-like lesions are produced which are very itchy. Young child cannot itch, so there will be crying episodes and feeding difficulties in the child. Older children and adults, there will be a lot of itching. That is a normal species. Then you have varieties of scabies called as nodular scabies and varieties called as Norwegian or crusted scabies. Nodular and crusted scabies both can happen in HIV positive individuals, AIDS patients. Additionally, crusted or Norwegian scabies can occur in immunocompromised like chronic immunodeficiency patients or primary immunodeficiency patients or on immunosuppressants or sometimes in mentally retarded patients, intellectual dysfunction patients as well. So what we are left with? Option number D, that is false. Why do I say false? A lot of students said, sir, permethrin cream is applied. Look at the percentage. It is 5% permethrin cream which is applied, not 1%. So because the answer is topical 5% permethrin cream application, you apply for 8 to 12 hours, then you wash it and then you repeat after 1 to 2 weeks later. That is the regime that we follow. So they are asking all are true except, and so the answer to this question is D. Also remember that in clinical practice, we also use a drug called as Ivermectin. It is an orally available drug. The dose is 200 microgram per kg. 2 doses will be needed 2 weeks apart. In immunocompromised person, in an immunocompetent patient, 1 single dose is good enough. It achieves close to 70 to 80% cure rate. So answer to question number 4, bio-exclusion is D. But if the option, this is based upon recall, if the option changes or if there is a non or subtle change in the option, the answer will change. So point here is to read about scabies as a topic. Moving further, question number 5. A child with a skin lesion as shown in the image and also is found to have epileptic spasm. What is the diagnosis and treatment? So this is looking like a typical lesion of a ash leaf macule. This is ash leaf macule which are seen in tuberous sclerosis, right? The same image obviously we could not find. We don't know what the image was, but the similar looking image I've tried to take from commonly available sources. And what is the diagnosis and treatment? So there were 4 options given. So this child is having tuberous sclerosis, and tuberous sclerosis can have infantile spasm, epileptic spasm, West syndrome. In West syndrome, the usual drug of choice is ACTH, but if it is associated with tuberous sclerosis, the answer will be vigabatrin. So answer to question number 5 is B. Hypomelanosis of Ito can also have hypopigmented lesion, but these are usually present in voles and they lie along the lines of Blaschko. I have discussed this point in my video lectures, right? So this is, if again, it will all come down to how the question has been framed. So the point to remember for your exams, for future exams, is when we talk about the management of West syndrome. West syndrome has epileptic spasm or infantile spasm, right? So epileptic spasm or infantile spasm. If in general they ask, then in these patients, the drug of choice is hormonal agents, that is ACTH. If that is not available, you can go for steroids. And the second line agent is Vigabatrin. Whereas in patients of tuberous sclerosis, the drug of choice is Vigabatrin. And if Vigabatrin doesn't work, then you can give a trial of ACTH. So the first line agent overall will be ACTH. If they mention tuberous sclerosis, the answer will be Vigabatrin. Moving further, question number 6. A SAM child, severe acute malnourished child, on day 3 not of life, day 3 of admission obviously, developed tachycardia, tachypnea and hepatomegaly after the initial stabilization. What could be the likely possibility? Before we go further, try to think the scenario and try to correlate with whatever you have read in the exam, and you will find that all the knowledge which you have read, it will start coming back to you. So SAM child, either Kwashiorkor or marasmus, probably having some complication, that is why he's admitted. He's admitted, you know that whenever a SAM child is admitted, he's admitted for 6 weeks approximately. First 7 days of hospital admission is called as stabilization phase. Remaining is called as rehabilitation phase, right? Stabilization phase, your focus is not on high nutrients, focus is on preventing the complication. First 48 hours is called as initial stabilization. Now initial stabilization was done. On day 3, this child developed tachycardia, tachypnea and hepatomegaly. If as a normal pediatrician I ask you, a child is having tachycardia, tachypnea, hepatomegaly, what should come to your mind? Yes, you are absolutely right. This child is having a CCF-like presentation. So any child who develops a CCF-like presentation in the first week of hospital stay in a SAM child, you should always suspect refeeding syndrome in the patient. So what could be the likely possibility? Refeeding syndrome. They did not put the word refeeding syndrome. They mentioned electrolyte abnormalities related to it. So let us have a look at the options. 4 options were given, and we know the answer to this question is hypophosphatemia. Why? Because hypophosphatemia is the hallmark finding whenever there is refeeding syndrome. Refeeding syndrome, I will briefly summarize it. Refeeding syndrome, there is inappropriate high calories given to the child, which causes hyperglycemia, which in turn causes high levels of insulin release. This causes increased cellular uptake of magnesium, phosphate, thiamine, etc. and produces their low state. In addition, there is involvement of the sodium pump, which can produce some degree of normo to hypernatremia and CCF like picture. ECF expansion can happen in these patients. So hypoglycemia will not be the answer. It is not seen. It is hypokalemia which can happen due to increased potassium intake, and iso to hypernatremia seen. Hyponatremia is not the answer. So the answer is very clear, C. I have already discussed this in one of the videos on PrepLadder, recorded almost a year back. So the point here is not to tell you that I have already taught about it. The point is to tell you that all these points are indirectly mentioned in the discussion. So you need to understand whatever thing you read it from Nelson, you read it from your text, or you read it from video, you need to understand and correlate with the MCQ. So refeeding syndrome occurs when high calorie feeding is given too soon or too vigorously in the stabilization phase. Factors are multifactorial. Hypophosphatemia is the hallmark finding. There is a reduction in phosphate, potassium, magnesium and also thiamine levels as well. Moving further, so answer, I've already discussed hypophosphatemia. Question number 7. Post-drowning CPR was done. Cerebral edema develops after how much time? Very controversial. 15 minutes, 30 minutes, 2 hours, 12 hours. What do the textbooks say? I looked at Nelson. Nelson says that cerebral edema can develop several hours after cardiopulmonary arrest. So A and B cannot be the answer. It is either C or D. In the limited time I had while I was compiling these questions, I went through review articles, I went through PubMed search, and I asked a couple of my colleagues. I could not find a precise reference to this question. The examiner who must have framed this question must have used some article which we frankly do not know. Obviously, if the reference comes up in the future, in the subsequent videos, I will clarify that. But I had to rely regarding this question. It is either C or D on the expert opinion. So I asked one of my close friends who's a DM in pediatric critical care in one of the leading institutes in the country, and he clearly said the answer according to me should be more than 4 hours. It is about 6 to 12 hours that cerebral edema normally develops. Similarly, another pediatric neurologist I talked to very eminent pediatric neurologist, not taking the name. So he also said the same thing, that the better answer according to me is 12 hours. So in this question, D is a better answer than C because it takes some time, a few hours, for significant vasogenic cerebral edema to develop to produce manifestation so that you can detect it. At subcellular level, you may find it developing early, but it takes some time for it to manifest, and usually we say that about 6 to 12 hours it takes. So the better answer among them is D more than C, right? No reference as I told you so far. Moving further, question number 8. In dyskeratosis congenita, DKC, which of the following is not seen or least commonly seen? So 4 options given. This is an indirect repeat question. One option has been changed, but it is an indirect repeat question from past papers. So leukoplakia, nail dysplasia, tooth abnormality, skeletal malformation. Leukoplakia is seen, nail dysplasia is seen, tooth abnormality is seen. Skeletal malformations are not common in dyskeratosis congenita. Skeletal malformations are seen in Fanconi's anemia. Now you know that there are many types of inherited bone marrow failure syndromes. Fanconi anemia and dyskeratosis congenita sometimes can have an overlapping presentation. In Fanconi's anemia, skeletal malformations are prominent, but no lacy reticular pigmentation is seen. On the other hand, dyskeratosis congenita does not have skeletal malformation, but pigmentary abnormalities and tooth abnormalities may be seen. Right? Let us have a look at the summary of what we have discussed so far. To save my time, I am showing you the snapshot of the discussion which I already had. So the classic triad was the thing which was actually asked in a past NEET SS paper. So the classic triad includes dysplastic nails, lacy reticular pigmentation of upper chest and neck, and oral leukoplakia, and additional cutaneous findings, dental abnormalities, and hyperhidrosis of palms and soles. Fanconi anemia does not have these findings, especially nail dystrophy and reticular hyperpigmentation. And so the answer to this question by exclusion is dyskeratosis congenita की बात कर रहे हैं, which is not seen. Skeletal malformations is not seen. All the 3 are present in a patient of DKC. Question number 9. Lenticular opacities are not seen in which trisomy? Easy one. This type of question cannot be prepared for. You can simply remember the findings and reach the correct answer. So trisomy 21, 18, 13 and trisomy 5. The classical clinical teaching is that lens opacities can be seen. They may or may not interfere with vision, but lens opacities can be seen in the 3 common trisomies and the monosomy 45XO, that is Turner syndrome. So Down, Patau, Edward and Turner can have lenticular opacities. What is the odd one out? Trisomy 5. If you need reference, Nelson reference is there. Nelson says that lens opacities of various types can occur in association with chromosomal defects like trisomy 13, trisomy 18, trisomy 21, Turner syndrome, baki cheez you can remember, but less likely to be asked in the exam. So easy one. So this was a straightforward question. This was not a repeat question, but a straightforward question. Now, straightforward doesn't mean easy. Straightforward simply means you apply some logic and you know the answer. Question number 10. A patient has been diagnosed with Rickettsial disease, but is found to be allergic to doxycycline. What is the alternative drug you will use in the patient? 4 options were given: azithromycin, tetracycline, chloramphenicol, ciprofloxacin. Let us look at the options one by one. Now, for Rickettsial disease, ciprofloxacin is not recommended for use. It is not recommended for use in pediatric population, so this will not be the answer. Tetracycline and doxycycline belong to the same category, and so if the patient is hypersensitive to one, you will not use the other agent of the same class, and so tetracycline cannot be the answer. Right? Answer is between A and C. If you are a treating physician or a treating pediatrician, you see the infectious disease wards, you will find that patients who have scrub typhus, we often start them on doxy. If doxy is not available due to any reason or not possible, we start them on azithromycin. So a lot of students answered at azithromycin. In fact, if you look at the textbooks, they say azithromycin and chloramphenicol both can be used. So the point here is which one is to be preferred. Let us take the help of Indian Academy of Pediatrics standard treatment guidelines released in 2022. This is the table. It says the drug of choice is doxycycline, right? We know. Rapid effervescence, IV formulation is also available. Tetracycline we are not going to use, so we will not talk about it. Chloramphenicol is the most common alternative for tetracyclines, and azithromycin is the preferred drug in pregnancy. It is recommended when doxycycline resistance is present. Now, when you go into now the question is not talking about scrub typhus, it is talking about rickettsial diseases in general. For life-threatening diseases like rickettsial disease, like Rocky Mountain spotted fever, Indian tick typhus, etc., you will find that Nelson 21st edition clearly says that if patient is having doxycycline allergy, chloramphenicol is the next agent to be tried. They do mention that azithromycin is an alternative, but most of the texts say that azithromycin is useful in doxycycline resistance. So remember the following points which I am going to tell you. It is controversial, it is heartbreaking if you got the question wrong, but remember for future questions, if they say rickettsial disease in children, in these patients, the drug of choice will always be doxycycline, right? If the question says doxycycline allergy, the next drug to be used will be chloramphenicol. But if the question says doxycycline resistance, the next drug to be used will be azithromycin. So please remember these 3 points for future questions. So answer to this question, what is the alternative drug you will use? Chloramphenicol is the better answer. Moving to question number 11. Mechanism of action of heparin involves interaction with or via which of the following? So we know the answer is antithrombin 3. Antithrombin 3, you look at this figure, unfractionated heparin, also called as simple heparin, combines with antithrombin 3 via pentasaccharide sequence. It inhibits factor 10A and thrombin and leads to its antithrombotic effect. Nelson also talks about it, that both of them, unfractionated heparin as well as low molecular weight heparin, interact primarily by antithrombin 3 interaction. Question number 12. A child developed features of gross hematuria with anterior lenticonus and sensorineural hearing loss. So the child is having hematuria, the child is having anterior lenticonus, which is a pathognomic finding, and ear involvement, and similar history is present in the brother. What is the likely diagnosis? The likely diagnosis in these patients, it is a straightforward, easy question. It is an easy question, Alport syndrome. I am not even showing the options. In fact, options I could not recall. The students didn't recall, but do you need options in such a question? The answer is no, you don't. Obviously, answer will depend upon the options, but Alport syndrome is, you look at the statement and you look for Alport syndrome in the options. And what does Nelson say? Nelson says that Alport syndrome, presence of anterior lenticonus is pathognomic. This is first point that you should remember. Second is, it is highly likely in a patient who has hematuria and at least 2 of the following characteristic findings: macular flakes, recurrent corneal erosion, GBM thickening and thinning, or sensory neural deafness, right? Although microscopic hematuria, recurrent microscopic hematuria is more common, but 50% patients can have gross hematuria as the presentation. Question number 13. Now this is a very, very difficult question, and it is also a controversial question, and the answer to this question will be changed if the recall changes. So rather than running after the option, focus on the points which I am going to discuss. Which of the following is true regarding dyslexia in a child? Let us look at the options one by one. Dyslexia is a genetic disease. It runs in families, usually inherited, where there is a problem in association between what the child is reading and what is the speech output of the child. I'm telling very basically, right? I'm not going into definition. So dyslexia is a problem of correlation. It's called as a problem of phoneme formation and processing. By phoneme, I mean the sounds which are associated with certain letters. So that association gets disrupted in the child. And dyslexia is considered to be one of the most common learning disorders in the child. So a lot of celebrities have dyslexia. I'm not taking the name, you would know it already, and I've discussed it in my recent video also, which I've recorded for PrepLadder SS. You can go through that in details. So let us look at the options one by one. So once you make the diagnosis, dyslexia is a clinical diagnosis. It is a clinical diagnosis where you can use investigation to rule out other options, but it is majorly based upon clinical history, examination, and doing IQ testing and doing specific test. It is majorly a clinical diagnosis. There is no rule of investigation. And so once diagnosis is made, Nelson clearly says that re-evaluation is not needed, revisiting the diagnosis is not needed. So B cannot be the answer. This is a false statement. Question is asking true, right? Functional MRI is the investigation of choice for diagnosis is a false statement. Functional MRI does show abnormalities in the posterior parts of the brain, but functional MRI is not indicated for diagnosis, right? Please understand the difference. It can show abnormalities, but it is not essential for diagnosis. Nelson also clearly mentions it. Fluency improves better than accuracy with therapy is a false statement. At 2 places in Nelson, It clearly says, and also it's a general belief that when you try to treat these patients by using various regimes, you find that accuracy of speech can be improved, but it will never be fluent. The child will always have slow reading speed. The child will be slow in answering the questions. The child will be slow in output of the speech. So there will be fluency will always be a problem. There will be too much of pauses in between. So fluency will always be a problem. What are we left with? Option number A. All cases do not have a heritable basis is a relatively true statement among the options given. Yes, majority of these patients have a heritable basis. One of the leading review articles says that 80 to 85% patients of dyslexia are found to have a heritable basis. But it is not that it is only inherited. It can be transmitted in the families, but some patients, about 10% or less than that, can also have de novo mutations which manifest in that child. You need to understand that dyslexia is a genetic condition, but a single genetic locus is not responsible. Multiple small gene mutations accumulate and they come together to cause problems leading to dyslexia. Now, most of these genetic mutations are inherited in nature. So once there is a child with dyslexia, we usually follow a rule called as 50% rule. This 50% rule says that if there is a dyslexic patient, 50% of his parents, that is 1 out of the 2 parents, should have dyslexia. 50% of his siblings will have dyslexia, and there is a 50% chance of transmission to his offspring as well. Right? What it also means is that it is not a condition which has a typical autosomal dominant Mendelian inheritance or a high degree of penetrance. It will vary from patient to patient, and there are patients in whom the family history of dyslexia may not be present, but the patient develops dyslexia. Once he has accumulated those mutations, those can be transmitted further. It is a very, very controversial concept. There are 2 schools of thought. One school of thought clearly says all cases are inherited, but there is another school of thought which says that many dyslexia patients, there is a history of some learning disorder, but they're not severe enough to call them as dyslexia. So dyslexia, all cases, when you say all cases, they do not have a heritable basis. And if you rule out options, A is the better answer among the options given. As I said, it is a partially true statement. It's a controversial statement. So the answer to this question can change if the options are actually different in the exam. It was tiring. It was tough for me also. So I can quite imagine the plight of you students. But at the end of the day, remember that 100% score is not needed for topping any exam. So there will be questions like this, right? So etiopathogenesis of dyslexia, you can be asked about extra thing about the neural signature. Neural signature refers to functional MRI showing MCQ. So this can be a potential MCQ for your exam. So functional MRI shows inefficient functioning of left hemisphere posterior brain system. Look at this image. This image is taken from Swayman. Non-impaired patient. This is the Broca's motor speech area, and these are the 2 posterior parts on left hemisphere which are activated whenever a person has to read and speak out, right? In a patient with dyslexia, these posterior parts are not functioning. So their activation is not happening, which will be seen on functional MRI. Broca's motor speech area will be overactivated as a compensatory effect, although the eventual speech output is affected. This is called as the neural signature of dyslexia, right? This photograph can be asked in the exam. So answer to question number 3, the better answer, not the perfect answer, better answer is A. Question number 14, which among the following is the most common symptom of Sjogren syndrome in children? So Sicca symptoms, polyarthritis, recurrent parotitis, hepatitis. The answer to this question is very simple, C. Now whenever we talk about Sjogren syndrome in children, about 70% cases are found to have a recurrent parotid gland enlargement and parotitis. So this is the most common symptom. On the other hand, if they say adults, in adults, dryness of the mouth and similar symptoms called as Sicca symptoms are most common. So if they say adult, Sicca symptoms, in children, parotid involvement, parotid inflammation, parotid enlargement will be the most likely answer. Question number 15. Artery not involved in polyarthritis nodosa. It's a simple one-liner. Pulmonary vasculature is not affected. The answer is B. Nelson also clearly says the pulmonary vasculature is usually spared in polyarthritis nodosa. Question number 16. One question was asked on the etiology of antenatal hydronephrosis. The options are not recalled. But the mostly antenatal hydronephrosis is, remember, that it is transient in nature. If transient was an option, that would be a better answer. But if they are asking etiology after transient, then it will be UPJ or PUJ obstruction, whatever is mentioned in the question. I have discussed it in my videos also. I have discussed it in a special YouTube session also. I have discussed this thing on as a reel on Instagram also. Still, if you have missed it out and marked it wrong, it does happen. It was an easy repeat question. It's a repeat question. So, etiology of AHN, antenatal hydronephrosis, ANH, Nelson says most common cause, transient hydronephrosis. Second most common cause, UPJ or PUJ obstruction. Third most common cause, VUR. Fourth most common cause is uretrovesical junction obstruction or megaureter. And other causes include PUV, ectopic ureter. PUV is posterior urethral wall, ectopic ureter, and uretrocele. So please remember this list. Already, now it is the second time this question has been asked in super specialty exam. Question number 17, easy one. Bartter syndrome is associated with which among the following? If you have given the last two papers of NEET SS, you would know that Bartter syndrome is one of the favorites of SS examiners. So Bartter syndrome is associated with which among the following? Hypomagnesemia. Usually magnesium levels are relatively normal. Rare forms can have slightly low levels, but hypomagnesemia is a feature of Gitelman syndrome. Low prostaglandin levels, wrong. Prostaglandin levels are elevated, and that is why indomethacin is effective in them. Option number C, low urinary calcium. Nope. It is increased urinary calcium which causes renal stones and nephrocalcinosis in the patient, and answer to this question is D. Easy one. Options rule out karna hai. So this table, which I have discussed multiple times at various forums, Bartter syndrome, Gitelman. Presentation, Bartter, it presents early in life, Gitelman, childhood or adolescent. Facial dysmorphism is a feature of Bartter syndrome, but not all patients. Some varieties can have it. Sensitive neural hearing loss is present in type 4 Bartter syndrome. Urinary calcium excretion is increased and it is decreased here. So this was the point on which this question was framed. Renal prostaglandin E2 production is increased and it is normal, and that is why indomethacin is effective here. Serum magnesium is normal. There are some varieties where slightly low levels can be seen, but low hypomagnesemia is a hallmark of Gitelman, not Bartter syndrome. And treatment here, supplementation is needed. Potassium and chloride, here potassium and magnesium supplementation is indicated. And indomethacin obviously because of increased renal PGE2 production. So answer to this question obviously D. Question number 18. EEG of absence seizure was shown. Which drug is not indicated? Now I don't have access to EEG, so I will not be showing it. Which drug is not indicated? Look at these options. We know that ethosuximide is the drug of choice. So this cannot be the answer. Valproate, again, it is a first line drug alternative to ethosuximide, so this cannot be the answer. Levetiracetam and lamotrigine are usually not the first line drugs, but can be used in patients of absence seizure. Carbamazepine is not effective. In fact, it is contraindicated in absence seizure. It can worsen absence seizures. And answer to this question is B. Please remember that carbamazepine can worsen absence seizure. It can worsen myoclonic jerks and myoclonic epilepsies. So remember that carbamazepine or oxcarbazepine, they are usually avoided in absence seizures. This is a very, very important point I am writing. And they are also avoided in myoclonic disorders. For example, juvenile myoclonic epilepsy. In fact, one of the students said there was a question related to JME also. We don't know. The recall is not there. But if such a question was there, again, carbamazepine will not be used. Now, there is an exception to this rule also. Carbamazepine is avoided in myoclonic seizures. However, important thing to remember, carbamazepine is effective. It is not avoided. It is the only drug which is effective, or oxcarbazepine is effective in myoclonic jerks or myoclonic seizures present in SSPE. So if myoclonic jerks happen in SSPE, for controlling those seizures, carbamazepine or oxcarbazepine are paradoxically the most effective drug. So this is an exception and can be a fresh MCQ for your exam. Moving further, question number 19. Liver transplantation is indicated in which IEM? The answer to this question is straightforward. It is tyrosinemia. What does Nelson say? Tyrosinemia has two problems. One, the liver dysfunction is happening, plus there is a risk of hepatocellular carcinoma. So it says that most liver nodules are benign, but current imaging techniques do not accurately distinguish all malignant nodules. For patients with severe liver failure not responding to nitisinone, liver transplantation is an effective therapy which can also alleviate the risk of hepatocellular carcinoma. So question number 19, although option D is not recalled, the answer is tyrosinemia. Question number 20, pulsus paradoxus can be seen in. Now there are a lot of causes of pulsus paradoxus. This is a indirect repeat MCQ. So if you got it wrong, the blame is on you. End of the day, I'm not blaming you, but the point here is we need to be strict with ourselves. If we get a repeat question wrong, or if we get an easy, straightforward question wrong, somebody else will not do it. End of the day, everyone who's sitting in the exam is MD or DNB in pediatrics, right? Please keep it in mind. So your accuracy should be superbly high. So pulsus paradoxus can be seen in. Let us look at the discussion which I had some months back. So I had talked about MCQ point for SS exam. I had already told that this is a question already asked in the past. It is a repeat question. So causes of pulsus paradoxus in children include cardiac tamponade, constrictive pericarditis, severe acute asthma, massive pulmonary embolism, severe obstructive pulmonary disease, tension pneumothorax, severe hypovolemic shock. And among the options given, it is pericarditis. 20% cases can have pulsus paradoxus, and so the answer to this question is B. If you try to do Google, some review articles will mention among rare causes post-perfusion syndrome also, but it is not classically seen associated with in children, and since it is a pediatric exam, the better answer among the options is B. 20% cases of pericarditis, constrictive pericarditis, can have pulsus paradoxus. Question number 21. Again, controversial question. Also, this question shows why you should read Nelson 21st edition and not Nelson 20th edition. True statement regarding renal morphogenesis. 4 options given. Nephron growth is completed by 36 to 40 weeks and continues postnatally for 2 years. We'll come back to this option. It looks very correct, but it is not. Look at the option number 2. Nephron number per kidney varies between 0.2 to 1.8 million. It is a true statement. Glomerular basement membrane has 6 layers. It is a wrong statement. Glomerular basement membrane has 3 layers. And postnatal attrition is common in renal development. Again, it is a wrong statement. What is postnatal attrition? Attrition will be loss of nephron. Loss should not happen postnatally. If loss of nephrons happens postnatally, then postnatal loss is going to cause chronic kidney disease in the patient, right? So it is never normal. They are asking about normal renal morphogenesis in the patient. So this cannot be the answer. What about option number A? If you look at Nelson 20th edition, it says that nephron growth is completed by 36 weeks or so, 36 to 40 weeks. And after that, the nephron growth doesn't happen. It is the tubular growth which continues postnatally for 2 years. If you read Nelson 21st edition, it says that nephron growth is completed by 34 to 36 weeks. Not 36 to 40 weeks. In fact, recent research has shown that the earlier cutoffs that we used for up to 40 weeks it can continue. It is actually completed much earlier. And that is why it is also a false statement. Answer to this question, they are asking true statement. Answer is B. I know some of you will not be satisfied. I have brought my evidence with me. So Nelson 21st edition, not 20th, 21st edition says each kidney contains 1 million nephron and there is a number of nephrons is 2 lakh to 1.8 million nephrons per kidney, right? First thing. Then look at in humans, the formation of nephron is complete at 34 to 36 weeks of gestation. But the functional maturation with tubular growth and elongation continues during the first decade of life. Nephron nahi. The entire nephron nahi, only the tubular growth, right? So tubular growth and elongation will continue during the first decade of life, but the formation is completed by 34 to 36 weeks, right? And glomerular basement membrane has 3 layers. There is a central electron dense lamina densa, then is a lamina rara interna and lamina rara externa on the 2 sides. So answer to this question. So that is why the answer to this question is the one that we discussed. It's a controversial question. Again, if the language changes, the answer will change. I think the examiner wanted you to know the answer to this question, wanted you to know that there are certain changes in the development time which is mentioned compared to the older editions of Nelson, and that is why some students said that there was another one-liner question, by which week nephron formation completes. So it completes by 34 to 36 weeks of gestation. That is the better answer. Question number 23. A baby underwent a liver transplantation for extrahepatic biliary atresia. He developed gram-negative sepsis, which was managed. Later, there was development of non-anastomotic biliary stricture. What is the likely etiology of this? Now, here also, Nelson gives you a clue that the most common early complication of liver transplant in young children is development of hepatic artery thrombosis. hepatic artery thrombosis can not only compromise the graft which you have put, but if you don't do transplant and only manage with thrombolysis, you will find that many of these patients can develop later on biliary stricture formation and related complications as well. So hepatic artery thrombosis can cause either graft failure, which may require, to prevent that, you may require either thrombectomy or more commonly they require retransplantation of the patient. Or if the graft failure does not happen, it increases the risk of biliary strictures and biliary leakage in the patient. Bilioma formation can also happen in these patients. The text clearly says that portal vein and hepatic thrombosis and their involvement is relatively less common. Overall, biliary strictures is the most common long-term complication, but the early complication is hepatic artery thrombosis, and it is seen that if there is a sepsis earlier, that sepsis again increases the risk of thrombosis in the patient. It is mentioned in the other articles. So looking at the question and the options given, the best answer here is hepatic artery thrombosis. Question number 24. There was a question on embryonal brain tumor in a child age group 5 to 7 years with chromosome 17 deletion, and 4 options were given. Among them, it is an easy one. It is an indirect repeat question. So it is an indirect repeat question. The answer is medulloblastoma. Even in my videos recorded more than a year back, I have already talked about medulloblastoma. It comprises 90% of all embryonal brain tumor, males more than female. Look at the age. Median age is 5 to 7 years. And here also the question is saying 5 to 7 years. 30 to 40% show chromosome 17p deletion. I had put a star also when I had discussed that. Along with that, there can be other abnormalities like p53 mutation, sonic hedgehog pathway abnormalities, and WNT pathway defects. WNT pathway defect medulloblastoma is a rare form, but this is the type of medulloblastoma which will have a relatively better outcome. So future they will put medulloblastoma, they very frequently put questions. So in the future they can put which among the following mutation or which of the following defect in underlying pathogenesis of medulloblastoma can have a better prognosis. The answer will be WNT pathway defect. So that is why topics will remain the same. Your accuracy, reading and Nelson grasp should be very strong. Question number 25. There is a case on short stature. The child had normal growth velocity, bone age was equal to chronological age, final height of the child was short. What is the likely cause of short stature? These are the options given. This is a relatively easy question, so try to see what is happening. So how would you approach this question? Child is having short stature. Whenever child is having short stature, you look at the growth velocity of the child. So there will be two possibilities. The growth velocity, also called as height velocity, is relatively preserved. It is normal. And second possibility is growth velocity of the child is found to be severely impacted. It is low. If growth velocity is preserved, we call it as physiological short stature. And this is the variety where you have pathological short stature. So you will have all the pathological causes that you read. In physiological short stature, you can have two possibilities. It is either constitutional delay in growth or you have familial short stature. In constitutional delay in growth, you will have chronological age more than bone age. Bone age is corresponding to height age, whereas familial short stature, chronological age and bone age are corresponding to each other, and both of them are in advance of height age. In constitutional delay in growth, there is delayed puberty in the patient, and the adult height is usually better. In familial short stature, there is no delayed puberty. There is only a family history of short stature, but puberty is normal and the adult height is always less. Why it is less? Because bone age is corresponding to chronological age, but height age is less, and that is why the growth plate fusion will also happen early in these patients. And so the answer to this question is B, familial short stature. Question number 26. Which among the following bacterial infection mimics acute appendicitis in children? There is an entity called as pseudoappendicitis, which is an infectious agent causing appendicitis-like presentation. most commonly caused by Yersinia enterocolitica in almost 85% cases. Rarely it can be caused by Campylobacter. Nelson also talks about it that pseudoappendicitis secondary to mesenteric lymphadenitis is a notable complication of Yersinia, sometimes seen with Campylobacter as well. And how will you distinguish? CT scan or ultrasound can easily distinguish them from true appendicitis. Question 27. Mother with SLE delivered a baby who was found to have second degree heart block at birth. If there is a mother with SLE, the child can develop neonatal lupus. And neonatal lupus is commonly associated with development of antibodies called as anti-Ro or anti-La. What is the next step in management? This question is taken from a flowchart mentioned in Nelson. Look at the flowchart and then we come back to the question. This is the flowchart. Now, the management of anti-Ro with or without anti-La pregnancy, whenever the child is found to have, or the fetal echo you are found to have secondary or alternating secondary or tertiary AV block, dexamethasone needs to be done, right? Serial repeat ultrasound echocardiography is not the answer here. Now, some people said it was a newborn mentioned, some said it was a fetus which was mentioned. In both the cases, dexamethasone needs to be started. Dexamethasone, obviously, in a prenatal case, will be given to the mother, which will cross placenta and reach the baby. So, answer to this question is C, start dexamethasone. Question number 28. A clinical case was there, a child aged 12 years, some people said 7 years, whether 7 or 12, it will not change the answer. Had features of proximal muscle weakness, positive Gower sign, CPK was within normal limits. What is the likely diagnosis? Let us look at the options. Myotonic dystrophy cannot be the answer, because it has distal muscle weakness and it also has other associated problems. By 12 years, the child will have myotonia, the child will have other manifestations, there may be facial dysmorphism, etc. None of them are mentioned, so B cannot be the answer. Becker's muscular dystrophy cannot be the answer. Clinically, these children can have proximal muscle weakness and positive Gower sign, but CPK levels are elevated. Silent elevation in CPK is seen in Becker's muscular dystrophy. You don't believe me? Look at what Nelson says. Nelson says BMD mein onset is after 5 to 7 years. Patient continues ambulatory, but calf pseudohypertrophy, cardiomyopathy and elevated levels of serum creatinine are similar to those of patients with DMD. Right? So, elevation will happen. Again, not likely. Why? Answer cannot be D. Nevelin rod congenital myopathy. It is a type of congenital myopathy where there can be some degree of muscle weakness, but it is distal muscle weakness which is seen, right? And you will find that these patients also have prominent facial, axial and bulbar involvement compared with limb weakness. None of them is mentioned. So this is also unlikely. What are we left with? SMA type 3. SMA type 3 is also called as Kugelberg-Weilander disease. This is in fact a relatively common variety of SMA. This can mimic muscular dystrophy. These patients will have proximal myopathy. So they will have a positive Gower sign and the CPK levels will be relatively normal in them. So the answer to this question is A, SMA type 3. Question number 29. Which among the following is a feature of benign innocent murmurs in children? So before we look at the options, let us revise the key points. Benign innocent murmurs, they are benign in nature, right? They do not indicate any disease. What is the most common age group? They occur in the age group of 3 to 7 years, right? Third, benign innocent murmurs, where are they best heard? They are best heard in the left lower sternal border or in the left mid-sternal border. This is the common site. They will show no radiation. There will be no radiation to apex, to neck or to back. These benign murmurs, they will change intensity. So intensity will change with respiration. They change intensity with position or posture of the child. What it means is, Nelson clearly says that they are attenuated or sometimes disappear when the child is put in sitting position or prone position. Right? Now, look at the options. Which is a feature of benign innocent murmur? They are a type of, remember that they are systolic murmurs. So, it is a diastolic rumbling murmur is a wrong thing. Often radiates to apex and back, a wrong thing. D option is not there. Intensity changes with position is a correct statement and that is your answer. Question number 30. 1 centimeter increase in subgaleal space can accommodate up to how much amount of blood in a subgaleal hematoma? Subgaleal hematomas are dangerous. Subgaleal space is wide. And so it is seen that even that subgaleal space, if there is a 1 centimeter increase, up to 260 ml of blood can be accommodated, which is almost sometimes in a young child, in a young newborn, borderline preterm and early term baby, it can be up to 60 to 70% of the total circulatory volume. Right? So what it means is that it can be life-threatening in the patient. So the child can develop shock, hemorrhage, etc. Shock, DIC, etc. as a complication, and death can happen. So if the question says up to how much amount of blood can be accommodated in subgaleal hematoma, if there is a 1 centimeter increase, maximum is 260 ml, and that is your answer. Reference for that is the RCH guidelines. Question number 31. Clinical features appear earlier in successive generation. So options could not be recalled, but when features appear earlier in successive generation and the severity also increases, that phenomena is called as anticipation. It's an easy thing, one-liner kind of question, easy question. So the observation of increasing severity of disease and early age at onset in subsequent generation is termed genetic anticipation. Where is anticipation seen? It is seen in triplet repeat expansion disorders. So triplet repeat expansion disorders like Fragile X syndrome, anticipation phenomena is seen. So remember, triplet repeat expansion disorder can be asked in the exam. Question number 32. Most common type of genetic mutations producing the disease. Overall, most common, one of the option was missense or nonsense mutation. They are the most common variants according to Nelson, followed by small deletions or insertions, right? Again, a one-liner kind of question. Question 33, a gene which is penetrated or present, but it is not expressed phenotypically. This is called as a non-penetration. It was one of the option and an easy thing. There is a concept called as epigenetic gene. Epigenetic gene kya karte hain? What do they do is, they reduce the expression of another gene, which separate from that, what you call as hypogenetic gene, right? Epi is the gene which is suppressing and hypo is the gene which is getting suppressed. So epigenetic gene can affect the expression of the gene. So that gene will be transmitted. In that person it will be present, but it will not be expressed itself. They can transfer to future generations, but that it leads to abnormal phenotypic expression, commonly seen in certain autosomal dominant disorders. It is commonly seen in Marfan syndrome also. So let us look at some of the key things related to taken from some standard text. That presence of epistatic genes explains the variability in dominantly inherited human diseases like Marfan syndrome and neurofibromatosis, and they are present but show only partial symptoms of the disease. Some in fact may show no expression of the disease causing gene, a condition referred to as non-penetrance. Right. Question number 34. There was a question on leukocyte adhesion defect and Bombay blood group. Easy one. Bombay blood group are associated with leukocyte adhesion defect type 2. There are 3 varieties. Type 2 is the mildest form in which Bombay blood group is often associated. It's a one-liner thing discussed in multiple forums. It's also often discussed in your NEET PG level also, right? So don't get it wrong in the exam. So in my video on PrepLadder SS part also, 1 year back, I've already discussed. You can look at the table. This is a very modern table. So you can take a snapshot and remember the entire table in case you don't have access to PrepLadder SS. So this clearly shows that, look at it here, special characters. LAD type 1 is associated with gum involvement. So tooth inflammation. Gingivitis, severe periodontitis type 1. If they say facial dysmorphism, Bombay blood group, neurological problem, LAD type 2. And if they say bleeding disorder, like Glanzmann thrombasthenia, LAD type 3. So this is a very, very important thing. Special associations of each 3 varieties of leukocyte adhesion defect. LAD stands for leukocyte adhesion defect. It is a type of phagocytic disorder included in primary immunodeficiency. Question number 35. A question was asked on the correct criteria for cyclic vomiting syndrome. Now the options were very confusing. I could not get the proper recall. So irrespective, let us briefly review the criteria for cyclic vomiting syndrome here. So cyclic vomiting syndrome is an idiopathic disorder characterized by repeated attacks or cycles of intense vomiting lasting equal to or more than 4 per hour with eventual resolution between the attacks. So cycles of repeated severe vomitings happen. Each attack lasts about 24 to 48 hours and responds to hydration. And when should you suspect? You should suspect if there are total 5 episodes or at least 3 episodes in 6 months. It affects 2% of Caucasians, the Western population, and females are more commonly affected than males. Family history of migraine or motion sickness is present in 30 to 40% cases. So this is an important addition of one-liner can be asked in the exam. Median age of onset is about 5 years. So it is a pediatric condition. Can continue into adulthood. But majorly what we find is majority of these patients stop having it by adolescent period. So it may outgrow the problem by adolescent period but may develop migraine in later life. So they will be prone to migraine in the adult life as well. Diagnostic criteria says episodic 2 or more attacks of intense nausea and paroxysmal vomiting lasting hours to days within a 6-month period. And stereotypical pattern and symptoms in the individual patient. Episodes are separated by weeks to months, return to baseline between the episodes, and not attributable to another disorder. In addition, there were questions related to rickets. Now the recall is not complete. Once, if I am able to find better recall, I will be posting additional videos. We'll go for discussion. The point here is not to look at the exact question. Exact question, these are not exact questions, right? The point is, in NEET super speciality, you have one particular area from where sometimes 2 or 3 questions are being asked. So accuracy, in-depth knowledge of Nelson and slight knowledge of related subjects, related topics is important. You cannot focus on only neonatology and think that you will get a top rank in the exam. If you are reading neonatology, something like a rheumatology also needs to be read with equal attention and dedication. That is what the point is. Balanced approach works in NEET SS exam. And there are a lot of topic repeats. Ricketts had 3 questions. All the questions are yet to be recalled, so I am not discussing them. I will not discuss questions which are on my whims. There were some one-liners related to 22q deletion syndrome being Tijot syndrome. The point of this discussion is to give you a direction, an idea, and all the points which I mentioned, you can add to your notes. Focus on Nelson, increase your accuracy, and do not go into unnecessary rare pathogenetic details. Focus more on the criterias, focus more on the Nelson based text. That is going to help you. I hope you benefit from it. Thank you very much.